right, thanks to whoever assigned me this talk. I really appreciate. Thank you, PK. Appreciate this. All right, let's have a conversation here. Okay. So the task at hand was PTAB. Where does it fit into my algorithm? Full disclosure: n equals 0. But sometimes when you get assigned a talk, you learn a lot, and you may change your practice patterns, or at least be more open to things, or kind of start understanding things more. So these are my disclosures. This is the Photoshop version of where I work. So come on by anytime. That's where I am usually. Okay. So what is PTAB? Where is it used? Why is it used? And when can it be valuable? Hopefully we get to an answer here. I don't know. So PTAB, for those that don't know, it's percutaneous transmural arterial bypass. The system is called Detour now. It was called PQ bypass before that. In general, you have an SFA occlusion, jump across to the femoral vein, which my fellow does accidentally almost every day, and then you purposely jump back into the SFA pop after your occlusion or lesion. And so in a cartoon picture in perfect vessels, this is what it looks like. So this is what you hope to achieve in this kind of a system. They have a crossing system device called the endocross, similar to kind of, if you think about it from theory, like an Outback, a Pioneer, and now use a lot of a BBAC. But basically, you're trying to get across next door to the femoral vein. You have a snare in the venous system. Now, the arterial side is an 8 French system. You can do a 4 French in the venous side from the tibial veins, come up and have your snare there for your proximal crossover. And then basically, if you just want to think about the steps, you're going to get a wire across. You're going to balloon that proximal origin just like we do for DVAs and other systems. And then you're going to cross over again distally once you get your crossing device now in the other direction. You grab that, you balloon it, and then you start putting stents. The stents are 6 millimeters typically distally and 6.7 millimeters proximally. God help us to figure out why these numbers of these stents and how they come up with the numbers, but it is. The stent is called Taurus. It's a self-expanding PTFE covered nitinol stent, similar to ones that we use in other scenarios. The indications from the company, and thank you Endologics for some of the slides on the data and stuff like that, for CTOs ranging from 10 centimeters to about 43, also for patients who have diffuse severe stenosis that may be suboptimal candidates for surgical alternative endovascular. More to think about that. And for PK, you cannot use this in the cerebral or coronary vasculature. So they put that there specifically for Sinai, yeah. So from the company, here's some example cases. CT coronal images, you can see a nice long SFA occlusion. I will point that you should see that this is a nice proximal stump for those of us who are endo-friendly. That seems like a gold mine when you think about having an origin to cross. So you cross from this proximal area into the vein next door, and you cross back over. As you can see in this beautiful picture, you can see kind of the step-off points where the stent enters and exits. Similar here, another one. Looks like clearly the patient has had some work done here before. This is a occlusion that was crossed over, and you can see again a nice laminar flow is what we expect from any kind of intervention, especially if you put stents or if you have a bypass. So the pictures look good. It seems like something that helps you deal with a long occlusion, which for a lot of us is a very complicated scenario, whether you have a CTO of calcium or whatever have you. This is a CLTI patient, same story, long occlusion, have a nice runoff afterwards. So they have a trial. Took patients Rutherford 3 to 5, lesions greater than 20 centimeters. They were considered in the trial, had CTOs, diffuse stenosis, or ISR. You can see the vessel diameters there. Some of the things they needed was an accessible SFA at the origin, a patent popliteal artery without significant disease, at least one tibial runoff artery to the foot, to the ankle at least, and interestingly, a patent femoral vein of greater than 10 millimeters, or even better if you have a duplicated vein. Contraindications for this, your common femoral is less than 7. You have an increased risk of DVT for a multitude of reasons that you can't control. If you have untreated inflow disease in the aortoiliac system. Also, if you don't have a tibial runoff, bleeding issues that you can't control. This is for the trial. And hypersensitivities to God knows what. PTFE, nickel, titanium, saline, breathing, all these other contraindications. Their patients were 202 patients at 36 sites in US and Europe. Finished in 2020, and they looked at safety and efficacy endpoints, as you can see here. I'm not going to go through all this stuff, but you can see the lesion length was 32 to 33 centimeters, and total occlusions with 96% of patients, which is great when you have this kind of patient population. You can see, interestingly, in the characteristics of the procedure, would be interested to hear more about a newer system used to create the distal anastomosis in about 20% of patients. So Just curious to know how that works out, especially when you think about from a cost nature how that works. Outcomes-wise, 100% technical success, procedurally 99%. Major related infections within 30 days, 0.5. Clinical success up to 2 years at 96%. You can see primary effectiveness endpoint, target was 60%, they were at 68%. And you see the freedom from MAEs at 93%. When you look at the charts, you can see primary patency, which at 1 year, 72, and at 2 years, 69. Matt, don't worry, I texted Sean, he told me what the actual answer was. So 69%, which if you think about the numbers that Stephen told us and the others, it's equivalent to what we hope to get from a long lesion from a bypass perspective or other, hopefully, interventional perspectives. Freedom from clinically driven TLR through 2 years at 77%, and freedom from 100% occlusion, meaning flow, no flow, at 87, 88%. This is interesting too, because this is the first thing that I thought of when I heard about this system a few years ago is, what about the vein, what about the DVT? And through 2 years, freedom from that was almost 96%. More to come on that. Freedom from major limb events through 2 years, 73%. Major amputation, 99%. So nothing that we would hope to be surprised by really any of this. PEs were 0, thank God. Hospital stay was low. This is an endovascular approach procedure. So the potential ideal patients per the device manufacturer is long segment SFA lesions, recurrent CTOs but not crossable, symptomatic claudicants with long lesions, poor open surgical candidates, and I think there's a lot of nuance to that. Christian says he can bypass anybody, so I know that the nuances are different to every surgeon. Recurrent occlusions, multiple failed endovascular treatments, CLTI patients, failed bypasses, and then refusal of surgical bypass, which you can convince any patient to refuse surgery. So here's what we got. We got 70% primary patency, which is kind of what we want. Clinical success, which is great. Freedom from major events, great. DVT was 4.1%, which is very low. It's not 0, but I keep thinking about this, like, what do we do with this? Because I don't know. I really don't know. Because, when we do this, I do a lot of venous work, a lot of PE work, a lot of, if we get one little morsel of a platelet in a vein, we all freak out. If the ultrasound shows some kind of shadowing, we all freak out. But somehow this works well, where you have a stent in the vein and it works out okay as long as your vein's big enough. So it's still a little mind-blowing. I mean, think about all the venous seals or whatever you guys do, and you freak out when you see a little bit of glue somewhere. So it works, and I don't really know. When I try to figure out, well, what's the natural rate of DVT in patients in general, when I look at 2022 Journal of Vascular Surgery Lymphatic, they said somewhere around 3.8, 4.8, I don't know. This is like all comers. This is interesting because in my patient population, it's 0, at least in my PAD patients. When I looked at, from the Voyager data, it was 1%. So I don't know, I mean, is 4% really that significant? I mean, in this patient population, I don't know the answer to that. It's more than 0. It may be about average for this patient population in general, so we don't know. For these cases, would it be better to do a PTAB? I don't know. This is an ISR, and that we're seeing in the live case right now. Is it better to do that or not? I don't know. I think it warrants at least an interventional attempt, and if it keeps going down, maybe consider this. But like we talked about, you don't want to have you need to have a good landing proximal zone of about 3 centimeters. So if you're going to put more stents like Vishal's doing and Robin are doing right now, you kind of take that out of the picture. In these cases, you can get a good result. In this case, similar thing. Would I do a PQ bypass here or a detour here? I don't know. It crossed relatively easy. But this one burned my bridges several years ago before IVL. It was horrific. You can see my wires doing a dirty dance in there. Horrible ballooning, horrible stenting. I wish I could say I wasn't the operator, but that's me, and that's what I was left with. This one would have been great if I had something else at that time and couldn't get a better result for pre-treatment. So I don't know. I think it's a new form of endovascular bypass so that we can keep a JIT and the rest kind of at home some days so we can do more cases using the adjacent deep vein. It may be viable for complex CTOs or recurrent ISRs if you keep kind of running your system there and keep trying to fight through these things. Data seems promising. There's a lot of nuances. You need a good-sized femoral vein. You need a good proximal SFA. You need a good runoff because you are doing bypass. But when I talk to some of the surgeons who use this who also back this procedure, which makes me feel a lot better, they think it's a viable option. It may be better than doing an open bypass in some of these patients. So I think there's more to it. I don't know if there's any lesions that most of us who do, a couple hundred cases a year can't cross, but that doesn't mean that's always the right answer. So I think we have to tease it out more, learn more about it. But we thought this was crazy years ago, and Stephen taught us that it's not. So we'll have to see more from this. So thank you, everybody.